So I'm going to be talking about advanced heart failure and really the role of palliative care. What I'm hoping we'll get through today is that people will appreciate what a palliative approach can look like in heart failure. They can appreciate the symptom burden in this population and then learn about some resources to provide a palliative care approach in advanced and end stage heart failure. What do I mean by a palliative care approach? Well, when we think about heart failure and palliative care, sometimes it's like a square peg in a round hole. And there are several reasons that that's the case. And the best way that I've explained this to people is to sort of do a little compare and contrast cancer with heart failure. Really, you can think of it as any organ or non-malignant illness. And it presents some challenges. And let me go through some of them. The first is when somebody has cancer, generally there's a point at which in their illness the treatment stops. That is the chemotherapy, which is really aimed at as an anti-cancer treatment. And so there's this kind of natural place where there's some opportunity for conversations about why the chemotherapy is stopping. In heart failure, the medications that we use for heart failure are actually the same medicines that we use to palliate patients with heart failure. The diuretics, the guideline-directed medical therapy are all helpful both at symptoms and life prolongation, as well as palliation. So that there is no natural opportunity there to bring in a conversation. Again, in cancer, there are many transition points that can bring up a conversation for providers and patients. There's the transition point between when a disease was curable and is now metastatic, or there's a disease recurrence. There's a transition point when treatment goes to more palliative treatment, et cetera, et cetera. But in heart failure, there really isn't that before and then after time. The trajectory is really important to realize that this really changes the way that we have to think about palliative care in this patient population. In oncology, there's generally a stretch of quite stable, feeling fairly well, going back and forth, getting oncologic treatments, whether that's IV chemotherapy or pill or immunotherapy. And in order to continue that therapy, you have to maintain a certain functional status, so you're fairly well. When things change and people start approaching end of life, it tends to be a fairly predictable decline at that point. And I think we know of lots of the referral criteria for palliative care units, for palliative care, sort of 3 to 6 month prognosis. And in oncology, that's actually not that hard to figure out. And then there's a steady decline. There's going to be some ups and downs, of course, but generally when somebody is bedbound and approaching end of life with cancer, you don't really see a sudden or dramatic improvement. We all know heart failure and other non-malignant illnesses, the trajectory really looks quite different. There's the initial admission and illness, and then with various treatments and therapies, people are well, again, for some amount of time, and this can be months, this can be years. And then they enter the phase where they have flares or exacerbations of their heart failure, and they're often in hospital. They might even be so sick that they're in the ICU, they may be on BiPAP, and they can be very close to end of life and then recover. And that pattern can continue for a long time. And that makes it very difficult for people to think about, well, when should we be thinking about a palliative approach to care? Because even though they look so sick here, they're almost at baseline when they get better. And this period could last as well, months and months and months. And so it can get challenging because of the trajectory. Another interesting thing is that when you have cancer, the images that you get, the CT scans, the ultrasounds, et cetera, there's this obvious progression of the illness that is visible and is something to talk about. People know in general when cancer goes to the lung or the liver or the brain, that's a bad thing. So there's this language to talk about with investigations and where the cancer is. That's not the case in heart failure. Even if you were to talk about ejection fraction. Half the people have, half the patients have normal ejection fractions and still suffer from heart failure with preserved ejection fractions. So there really isn't a way, again, to talk about the palliative approach or to talk about palliative care needs. Understanding is really different. In cancer, although there's definitely a variable understanding about the trajectory of the illness, for the most part, when somebody has a diagnosis of cancer, they think about death. They know people who've died of cancer. It's a well-known sort of cultural thing. And so when they're getting sicker, it's not that hard to kind of bring that back up. But in heart failure, almost nobody I've met connects the two, that heart failure is something that is actually a terminal illness that can lead to end of life and shorten your life. The understanding is, I have a weak heart, or I have fluid trouble, or my kidneys and my heart, they're not really cooperating. There's all sorts of things, that the ways that we talk about it, but it doesn't actually usually connect to end of life conversations. So that's something that we have to take more time with for patients. So, okay, so we have all of these challenges. What does that mean? Well, when I think about putting a square peg in a round hole, there's sort of two ways to do it. We can chop away at the poor square peg so that it fits into our palliative care round hole, or we can stretch and grow ourselves so that it fits nicely. And what I'm going to talk about now is ways that we can stretch ourselves, including palliative care programs, but more importantly, primary care practitioners and home care practitioners, so that we can fit the square peg. So how do we know? A lot of people will say, well, how do I know when somebody, needs palliative care? If I can't prognosticate, if I can't say their prognosis is under 6 months, how do I know? And the fact is that we need to stop thinking about prognosis as a way of identifying people who would benefit from palliative care. We have to think about their needs, not their prognosis. And how do you determine their needs? Well, really, it's pretty much a conversation with them, but one of the screening tools that can at least start to identify who might benefit from some needs assessment is there's a SPIC tool. There's a lot of tools, but I like the SPIC tool. It's out of the UK. The link is here. And this is just a quick screenshot of things that you should look for. So, and this will be familiar to all of us who take care of people with chronic illnesses. If you start to see more unplanned hospital admissions, if you start to see their performance status is getting poor or deteriorating, you sort of look at the patient, you think, oh, you used to come in on your own, and now you're coming in with your daughter because it's a little bit hard. Maybe you can't park in the parking lot and get here without help. So that's the sort of thing that you're looking for, that you're depending on others for care. There's progressive weight loss, et cetera, et cetera. These are pretty standard. And those are the things that start to make you realize that somebody is more at this side of the trajectory than the earlier side. And what you'll see is, even though they're returning to baseline after an exacerbation, the baseline is still decreasing. So that's what you're looking for. You're looking for the baseline decreasing. So another way to think about it is there are some consistent predictors that tell you that somebody is in the latter half where they may benefit from a palliative care approach, or even some assessment. So older age, obviously, these are all, again, evident, increasing frailty, diuretic resistance. So if you've got a patient who you see now is needing metolazone, or is in hospital and needs inotropes for fluid balance, then those are people who are becoming more towards the end of life part of the trajectory. People with hyponatremia, people with elevated or rising BUNs and creatinine, and really importantly, you'll see people start to have repeated admissions to hospital. And that really speaks to diuretic resistance and to renal dysfunction that's happening alongside their cardiac dysfunction. So what can we do? So there's a number of things here I want to walk you through. The first thing, and we tend to forget about this, which is to really assess their illness understanding. it's hard to support people if they actually aren't aware of what's happening. And that can seem like a very threatening thing for people. It's, we're kind of bad news bearers. And I think that that sort of attitude comes out when we say things like, does your patient understand they have a serious life-limiting illness? And that's typically what we say. Do they know how sick they are? Do they know that this is a life-limiting illness? And I think that that can be very threatening both to patients and to providers, actually. Nobody wants to sort of create the appointment where we're going to talk about your serious life-limiting illness. So I like to flip it and think about us and providers as a guide and a support. We can be a guide through that trajectory and a support so that they know what to expect and what help is available. It's actually a really critical role for us. Patients and families, for the most part, want to know. They want to know what to expect. They take our silence about the future as everything is fine, there's nothing to talk about. It is an important role for us to be able to be the people who provide the education and support and even navigation. Offer to be a guide. This is actually how you can express your caring and your kindness. You can't reverse their heart failure, but you can definitely support them through this process. And they don't know there's a process to be supported through if we don't talk about it. So one of the things that I do, and this has been really, really helpful, is when I'm meeting with patients, I'll actually draw out a trajectory for them that shows the ups and downs and how the ups do actually sort of go down over time. The baseline is never as good as it was. And so I've just got a little language here. I don't say this over and over, one after another, but this is the kind of language that I found helpful. So I might say something like, this is what heart failure is like. The ups and downs, the going in and out of hospital, that's actually part of the illness. It isn't anything you're doing wrong. A lot of people think that by ending up back in the hospital, there's something that they're doing wrong. And when you explain that actually this can be a normal pattern of heart failure, ideally we keep them out of hospital, but it really is a relief because I think people think they're doing something wrong. I sometimes will say, we're working really hard to keep you up here at the top of the trajectory and as well as possible. You've probably noticed though that you're getting a bit weaker over time. And then if you want to introduce more end of life conversation, I usually say something like, at some point, the medications aren't as helpful. They just don't work to get the fluid off. The heart and the kidneys are not really able to respond to the medications. And at that point, people may be approaching the end of life. And we will continue to support and to help you whenever that happens. So just to give you a little sense of the language that I found helpful. This is a little plug for a podcast that I want people to sign up to. It's really awesome. This is Xian Xiao and Samantha Winemaker. This is for both patients and families and for healthcare providers. And it really talks about how to become more knowledgeable about chronic illness and about the future and how to speak about it with your clinicians. I won't spend too much time here, but they really talk about 7 keys of becoming more in the know about your illness. And it's a fantastic podcast. So I highly recommend people look at it or listen to it. What else can you do? Okay. Assessing and treating their symptoms. We're going to talk about that in a minute. Collaborating with the cardiologist if needed. If your patient is followed by a cardiologist, then connect with them, because I think one of the best things we can do is integrate patients' care. Often people have more than one specialist and they can get mixed messages. They can be told one thing about their fluids at one specialist and another thing about their fluids at another, right? The nephrologists want more fluids, the cardiologists want less fluids. It can get really complicated. The respirologists want steroids, you can't have steroids. So it's really good if as primary care practitioners, we can help the specialists work together and with us so that we don't give them mixed messages to our patients. Assess also their need for home care supports. That can be very helpful for preventing exacerbations. Nursing and PSW support can help with daily weights and with identifying symptoms before people get so bad that they need hospitalization. and also assess the caregivers as well. A lot of these patients are elderly and their caregivers are elderly and are really struggling. So the other thing that we can do is assess and manage symptoms. And although this could take a whole talk, I'm just going to run through this really quickly for you guys so that you get a sense. So for dyspnea, that would be one of the most common symptoms. And aside from, of course, guideline-directed medical therapy, there's diuretics. And if people are still symptomatic with dyspnea, low-dose opioids if needed. If the goal is to stay home, consider a palliative care consult, as we've been building capacity in an integrated palliative and cardiology approach where we can manage diuretics at home. For depression and anxiety, which are very common, SSRIs are safe. For insomnia, that's often multifactorial, but make sure that you ask about any anxiety about falling asleep, as people have often experienced dyspnea at night. Hypotension is only an issue if it's symptomatic, at which point you'll want to adjust some of the blood pressure lowering medications. Pain is treated the same way pain is treated for all our patients. Of course, we can't use NSAIDs in this population. And lastly, nausea and anorexia are very common, and metoclopramide is safe in this population. Also encourage small meals, and people can add a small amount of salt at the table. If they just take a pinch at the time that they're going to eat and sprinkle it on their food, that's actually a small amount of salt, and that is safe. So we can see that if we stretch ourselves, we can see that palliative care can be integrated throughout a non-malignant illness, not just at the end. Because often the end is unpredictable and people have multiple needs long before they're at the end of life. Their needs are both symptoms and to help with illness understanding. Lastly, just a few resources. You can look up in CFP, there's an article here about an approach to advanced heart failure. Core Health has some great resources for patients and healthcare clinicians around deactivating ICDs. And lastly, LEAP teaches a 3-day in-depth course in palliative care. And one of the sessions includes liver and heart disease. And so that's a good opportunity for extra learning. Thank you.